Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. Hi everyone, welcome to Melanoma Matters. My name's James Larkin.
And my name is Sapna Patel.
So today's going to be our third neoadjuvant podcast. And today we're going to be talking about S1801. So it's cool that we have you, Sapna, to do that. So before we do that, though, sort of warm up type of question. What were you like at school? Were you a nerd or were you cool? Or bit of both?
Both can be true. Come on. For the next podcast, I'm going to wear my student council sweatshirt from high school that I still have and fit into. It's
Sorry, for my benefit and other people, is that nerd or cool? What does that mean?
Student council was the elected body. So your fellow students elected you to be president of the student council or vice president or treasurer or a representative. I think I was just a representative. And you're usually on with, the jocks and the cheerleaders and the popular kids. So it was either a sign that my high school liked to put nerdy people, like acknowledge the nerdiness, or it was a sign that I was slightly cool. I think both can be true.
Yeah, you sat on the fence a little bit there. I might ask you that again another time or another way. See if we can get a little bit more traction.
Call us a secret guest from high school. Was she cool or not?
Yeah, that's a good idea, actually. Anyway, so S1801, so a very important study, rightly getting a lot of attention. But maybe before we go through it, could you tell us a little bit about the setup? What was going on at the time the study was designed, and why was the study designed in the way that it was?
Yeah, thanks for asking, so I can just give people the background. We never get to kind of talk about it. By the time we were developing it, I think I've told you the naming convention of SWOG studies before. 18 refers to the fact that it was designed and approved in 2018. The 01 just means it was the first study, for SWOG that year or out of our committee, whatever. So basically 2018 is when we were designing it, which means we were really talking about it in 2017. So this is before all of the first kind of tranche of really popular neoadjuvant publications had been published, really in Nature Medicine, as it were. But we knew about them all going on. We knew MD Anderson had a pilot study. We knew Utah was doing, Memorial Sloan Kettering, Netherlands, Melanoma Institute of Australia. And each of these places were investigating a form of preoperative melanoma systemic therapy. We had seen in the melanoma space that immunotherapy was looking good. Combination immunotherapy can be used there. Single agent can be used there. And there was already kind of a feeling that, okay, let's move to neoadjuvant therapy. But now all these regimens existed. There were of varying durations. There were varying adjuvant regimens and of varying durations. And there had still not been a head-to-head study saying if you do neoadjuvant and compare it to essentially the same thing in the adjuvant setting, that those neoadjuvant patients were having a better outcome. There were studies that were optimizing the regimen. So the neoadjuvant doublet regimen, full dose, inverted dose, sequential. There were studies looking at a single agent versus a double in terms of toxicity and being able to make it to surgery. So that type of regimen. There were studies of targeted therapy, but there wasn't really the study that said, if you do this compared to adjuvant, you will have better outcomes or not, or you'll have more toxicity, or you'll have the same outcomes. You've just moved, the sequence of things. So at the time we had S1404, which was a large adjuvant anti-PD-1 versus investigator's choice study. So it was pembrolizumab versus investigator's choice IPI or interferon. And we were really just trying to turn this into an amendment for that study. So this was S1801 was always supposed to be an amendment to S1404. taking the experimental arm of 1404 and turning it into the control arm. Adjuvant PD-1 is the standard. Now let's do. That was too far ago for the National Cancer Institute, who reviews our studies and basically has to approve it through SWOG, for SWOG. They reviewed it and they said, what you're proposing here is an entirely different study. The experimental arm is becoming the control arm. That's not just an amendment, that's more than that. So we really designed it fresh. And then the question was, should we compare regimens, so on and so forth? And we said, let's just ultimately put a pin in this. If adjuvant therapy is what everybody's doing, at this point, Checkmate 238 was the standard of care. Keynote 054 was, having signs that it was becoming positive. If adjuvant PD-1 is how everybody wants to treat their melanoma patient in the adjuvant setting, let's not rock the boat. Let's use that as our control and just alter the sequence, move a few of those doses preoperatively and change nothing else. Don't change the surgery. Don't change how much, just change literally the timing of everything, the sequence. We also were very careful. There was conversation to say, should it be 3 doses of neoadjuvant and then a full year of adjuvant? In other words, they would both have a full year of adjuvant, but the neoadjuvant would have 3 extra doses. And that's intriguing because you could definitely then say contribution of components. It's this neoadjuvant 3 extra doses that did something. But in my mind at the time, if we were going to have any sway with this study globally, regimens that had a financial imbalance would be looked at by health ministries. They would say, yeah, there's a benefit here, but the benefit is not outweighed by the extra cost of this regimen. That was my thought. We thought we would have a slight benefit and the cost wouldn't be looked at favorably as additive. So then they would say no. So we said, why don't we keep the doses the same? That way, if there is a benefit, financially, it doesn't have an impact on health ministries. So that's really the origin story, the X-Men story of S1801, if you will.
Yeah, I love that. So started life as an amendment. That's fantastic. I wish I'd known that before. But I guess we all try and get things through as amendments if we can, don't we? And sometimes you get lucky. All right. So that's great, the background. So then what about the study design, maybe in a little bit more detail at endpoints and stuff like that?
Yeah. So this study design took resectable melanoma, so stage 3 or 4. If you had stage 3, we needed you to have demonstration of lymph nodes involved. You could have in transit only. That certainly was allowed. It turns out it was a very small portion of the enrolled population, but we just need some clinically measurable melanoma. So that's either in transits that you could measure, lymph nodes that you could measure or reliably follow, or oligometastatic disease. So we designed the study to randomize patients 1-to-1. They would get the standard approach, resect all gross disease, not disgusting for the Ryan Sullivans of the world, just all clinically apparent disease, and then do adjuvant PD-1 for 18 doses of flat dose pembrolizumab every 3 weeks, or take 3 of those 3-week pembrolizumab doses before surgery, do another scan, then go to surgery, resect all gross disease, and then do 15 doses of adjuvant PD-1, both regimens getting 18 doses. Because this was a neoadjuvant study, our primary endpoint was event-free survival. It's almost the same as adjuvant studies. Adjuvant studies are basically telling you about freedom from your disease. So melanoma recurrence-free survival is usually the primary endpoint of adjuvant studies, but that wouldn't be enough in a neoadjuvant study because it's not just about freedom from survival, or freedom from recurrence, because these patients may not have yet had their disease resected. So it's not having progression and not having progression that would make you inoperable. So you could have some flare in your lymph node, but if the surgeon says, I can still get that out, I'm comfortable, that's not really an event. That's just worth noting, on a waterfall plot that there might have been some increase. So event-free survival would be defined as missing surgery. You didn't get that cardinal event in your neoadjuvant operable melanoma setting. And you could miss surgery for a couple of reasons. One would be your disease progresses in a way that it's no longer operable, metastatic disease. The other would be toxicity. There was another one that crept in because of when the study was done, and it was done around COVID, where patients just didn't want the surgery. They were trying to minimize exposures and they didn't want it. They were comfortable just getting drug. There was another setting related to that where patients took neoadjuvant therapy and would have an excellent outcome. And then they would question why they even needed surgery. Why do I need surgery if you can't even see it anymore on the scan? So we talked with the National Cancer Institute and said, let's not count those as events because that's a little bit more of a patient preference. And let's just count and make sure we're not having too many of those. And we didn't. We had one or two of those. So missing surgery due to disease progression or toxicity, disease that progresses in a way that precludes surgery, melanoma recurrence after surgery would be an event, and then death from any cause. So that actually is now capturing some early, I like to think of the E and EFS as early. It captures some early things that happen before the start of adjuvant therapy. By definition, patients who are reported on an adjuvant trial have not had an early recurrence because they got their disease resected and sat down for their first adjuvant therapy without recurrence. But we know there are some melanoma patients that recurred, and now we can quantify what that is, what percentage that is. So the E will catch people who progress early and miss surgery and progress postoperatively and miss adjuvant therapy. And now you need EFS to define that also for the toxicity point.
Yeah. Anything controversial in there, do you think? Do you think that's all sort of standard stuff for a neoadjuvant trial?
I think it's all standard. We had this finicky discussant at our presentation at ESMO in 2022 who harped on our sample size because when you do these event-driven studies, you enroll up to a point, up to an amount of patients. Because the idea is you expect, if you enroll a certain number of patients and the events haven't happened yet, you just wait for the data to mature. And then you look at things like median event-free survival, overall survival. You don't keep enrolling. You just sort of enroll until you think you hit some critical mass. And that's all statistically driven. So we had an upper bound of enrollment of 500 or until we had X number of events, which was about 101 events or so. Once we hit that number of 101 events, you would stop enrolling because if you've hit that events, that means something has happened statistically that you don't need to either expose more patients to or you could pause and then reassess. So we hit that number of events. We looked at the data. It is what it is. And that happened at 313 patients enrolled. And so I think there was a lot of controversy at the very beginning. Why didn't you enroll the full 500? Why? Because event-driven studies don't have to enroll up to that enrollment number. They enroll to that enrollment number if they haven't hit the number of events or until they hit the number of events, which can happen sooner than expected. And that's what happened here.
Yeah. So listen, I think we need to say, don't we, for the benefit of anyone listening or watching, that I was that finicky discussant, I think. Apologies. I hope we're still friends. And I should say congratulations as well, because this was in the presidential symposium, one of the presidential symposia at ESMO 22, NEJM publication for the record, actually quite a while later, I thought, sort of Q1, Q2, 23, not quite sure why it took that long. I'm sure it wasn't on your end, but anyway, so that was great to see the manuscript. And so then maybe tell us a few different questions. I guess the efficacy is number one, but I'm obliged also to ask about toxicity. And when you get to it, I want to know what your feeling is really about, was there anything, in the neoadjuvant arm that we kind of wouldn't have anticipated? And then I'm just, third thing's just a practical thing. You use 3 weekly pembro. Would 6 weekly be okay, given that lots of people are probably doing that and there's a bit of a resource, implication of 6 weekly versus 3 weekly in various, jurisdictions around the world?
Yeah, I mean, lots of obviously good questions there. First, let me just speak to the publication. We actually submitted this article as a rapid release right before the ESMO presentation, hoping to be able to say, and now in print. It just didn't get reviewed. Usually that bypasses reviewers. It just is an editorial approval, and we didn't get that. We weren't granted that. That's okay. It was reviewed, as we were basically presenting it at ESMO. We responded to those comments pretty quickly within about 6 weeks and had it, resubmitted end of October, November. We were told in December it was accepted, but I mean, I know you're familiar with just the publication process. We were told it's accepted, it's embargoed until we tell you it's not embargoed, and we can't give you a publication date right now. So 3 months after we were told it was accepted, it was actually published. And that's just the timeline. So that ends up being, 6 months after the presentation and the data was made public. One other comment is we had a finicky reviewer at the New England Journal of Medicine, statistical reviewer, who claimed that, it was not you. It's not you. Who claimed that these risks were non-proportional. And so applying something like a Cox proportional hazard ratio to our curves was not appropriate. I've heard people say this before. That's definitely one viewpoint, but it's not necessarily a standard viewpoint. Many neoadjuvant trials, are published with the Cox proportional hazard. So we did not publish our hazard ratio in that publication just because it had already taken so long to get it approved and in print. We didn't want to go toe to toe with this reviewer and delay it further. In hindsight, I realize now many health ministries have contacted me and they were looking for that hazard ratio in order to have some sort of jurisdiction about approving it. And so now I realize the importance of that. It's not just fussing with a statistical reviewer, but it's really making a point. I also, feel a little more grounded in being able to probably stand up for what we know is correct science here. Okay, so that's the publication. The second question you asked was about any toxicity. That's hugely important. As I said, one of the events that is defined as toxicity that precludes getting to surgery. Another way to look at it is toxicity that precludes starting adjuvant therapy. And as we know with single agent PD-1, there is some of this. There was one patient who missed surgery due to toxicity, and there were an additional 3 or so, I'll triple check myself and correct it if needed, who didn't start adjuvant therapy due to toxicity. And we presume that toxicity is from the systemic therapy, nothing really to do with surgery. And these toxicities are the ones we know. It's colitis, pneumonitis. There was a patient with essentially a predisposed rheumatologic condition, but it had been stable and not needing treatment for years. So felt like that would be a fine patient to treat. And then it emerged after single agent pembrolizumab. And then, because of that, it didn't feel like it was safe to give that patient adjuvant. And that we would support that decision that site made. So a little bit of toxicity early, one patient out of 150 some, and then a little bit of toxicity that led to no adjuvant therapy. But toxicity, the take home with single agent PD-1 or, as toxicity is not really what limits you here. The real maybe point to make is you can have patients where single agent PD-1 is not enough. And so you give them single agent PD-1 and they develop metastatic disease. Now, one viewpoint is you spared those patients an unnecessary surgery. You spared them a surgery that they didn't need that was not going to stop distant metastasis, because nothing about surgery is stopping distant disease. It's helping with local regional control, unless you think you're intercepting the process early enough. And that's just hypothetical. So one viewpoint is you spared them unnecessary surgery. The other viewpoint would be, is there a stronger regimen that these patients could have had where they could have still had surgery and had an excellent outcome? And that's really an area of investigation. And then you had a third question, and I've already forgotten it.
Well, yeah, the other question was about 3 weekly versus 6 weekly, but I don't think you actually told us the headline efficacy here yet either.
Oh.
So maybe that's quite important.
That is important. So the group that took neoadjuvant adjuvant, and that's how we decided to make sure it was clear, it's neoadjuvant with adjuvant. That group had a statistically significant improvement in event-free survival compared to the adjuvant-only group. And, the headline, the hazard ratio here was 0.58. And with the significant two-sided p-value in favor, obviously, of the neoadjuvant adjuvant arm. And that's important. So that's event-free survival. Now that's limited by short follow-up. Overall survival is still immature, so we really can't say anything about overall. And ultimately, that's what matters here. We want to make sure these patients are living longer in the long term. But ultimately, if they are having recurrences, maybe what we salvage them with is able to improve, bring their overall survival up to par.
Yeah, so I think that the landmark at 2 years for EFS was something like 48 versus 72, right? I mean, that's a big difference, right?
Yeah.
Big
Thanks
difference.
For knowing this number so well. Yeah. Yeah, that was unexpected, truly, truly unexpected. I will tell you, maybe just as a side note, so I went through every single chart on this trial, and for sure, every single neoadjuvant patient's chart. I went through their baseline scan and made sure those measurements lined up with what they entered. I went through their pre-surgical scan, made sure those measurements lined up with what was entered. And then I went through their follow-ups to make sure, did they have a recurrence or not? And so I made my own sort of spreadsheet on these 313 patients. And our statistician, based on a rough entry that the sites had done, was able to run an analysis early on, months before the presentation. And I said, don't tell me, I don't want to know, because I know there's going to be a lot of querying and cleaning that sites have to do. So let me go through all these 313 charts, issue the queries to sites, and then maybe a week or so before the abstract is due in August, we can do an analysis. But give me the summer. Don't tell me what's going on. Okay, fine. So then I took a holiday in Florida, and it was a beach holiday. And I basically sat out at the beach and the pool every day and just on my computer, doing the chart review, issuing queries, reviewing, entering my spreadsheet. And finally, at the end of that week, we had about 90% of the patients enrolled and data entered at that point. I said, okay, I think I'm done. I think we've gotten the queries we're going to get. I think I'm ready to have you crunch it. So Megan Othis, our statistician for SWOG, she crunched it in, no time, right? Because I said, go, here's the clean version, go. She does it in just a matter of hours and texts me, this hazard ratio, these numbers, and it catches you because we expected a 0.85. We expected 0.85, 0.8. We expected some nice benefit, but to see a hazard ratio that substantial, in a phase 2 study, it was pretty gratifying. And I stand by the, veracity of this data because I went through every single chart myself, as the investigators know, because they got friendly emails from me saying, please fix this, please look at this, please enter this.
So that's a great picture. You sitting by the pool in Florida, presumably with a cocktail or two.
Well, only after I would do, my set amount of charts for the day, not pre, and with loads of, sunscreen and a big hat, of course. So.
Of course, that goes without saying, I think, doesn't it? So couple of things. One is to ask you about when we might see some overall survival, and obviously don't say anything that you shouldn't. You still haven't answered the business about 3 versus 6, so that's another one. 3 versus 6 weekly pembro, does it matter? And then where do we go next is the other question, okay. I think.
Great. So overall survival, I think it's still going to take years. We reported this at 2022. The last patient was enrolled in 2022 and went to surgery at the end of 22, if not early 23. Let's assume the average survival now is pushing, 3 to 5 years, maybe not all the way to 5 years if you're using single agent, but this is earlier setting than metastatic disease. I think it's still going to be a few years before we have that. Also, we have to make sure we get these sites to continue to enter survival. That's one of the things, as you know, running clinical trials, sites need to remember to do their data entry and enter survival. When a patient recurs, they move them on to the next treatment. They don't think about, oh, I got to go update the trials that they were on those databases. And we got to have funding that supplies all that. Number one. Number two, 3 versus 6 weekly. This came up during the execution of the trial. It was COVID. People wanted less touch with their medical centers. We spoke to the sponsor, to Merck, about that, really. They weren't the sponsor, so to say, but they provided the drug. And it was just going to be difficult. It was just during COVID that data emerged of 3 versus 6 weekly. And as you know, it emerged in a presentation at a meeting, not in a publication. And maybe also only in metastatic disease, like not in the early. So, while we all believe that dose is equivalent, 3 and 6 dosing, the flat dosing, we couldn't change the study. Also with neoadjuvant arm, it was 3 doses of 3. How do you change that to 6? That would be very challenging. So we just didn't want to have any issue comparing these study arms, so we didn't do it. If you wanted to do it in the real world, I don't know how to do it. I don't know. Is it 1 dose of 6 weekly? Is it 2? As you've heard me say before, I'm very interested in receptor occupancy. So I would love somebody to do 1 dose of 6 weekly, do receptor occupancy, do 2 doses of, the 3 weekly, do receptor occupancy, because maybe that 1 dose is saturating the receptor maximally anyway. Anything you take after that is just contributing toxicity, but we don't know. And
yeah, quickly. So I do this in the real world. I do 6 weekly. So we're not going to have a a regulatory or reimbursement discussion about this today, because that is in itself a complicated and actually important subject. But I guess the top line there is that in terms of regulatory approval and reimbursement in most of the world, that's not straightforward for this at the moment, but maybe I'll just park that there for the time being. But when we can get reimbursement, and sometimes we can, I tend to do 2 doses of 6 weekly and then make sure the surgeons are kind of lined up. And I say, look, the important point is the timing of surgery from the initiation of treatment. And then it gives them quite a sort of big wide window in a sense.
It does.
Yeah, you're
with one point, James, that you don't have to get them all the way 6 weeks past the second dose, right? You could take them to surgery at whatever point that surgeon is comfortable, 1 week, 2 week, 3 weeks. But you're right. You've given them a big runway for that.
Exactly. So it's I kind of, to say I sign them off, it's not exactly correct, but we give the second dose of treatment. We make sure their scans are lined up. We make sure the surgeon's seen them. They're in the operating diary. We alert the pathologist, all that sort of stuff, which you were talking about, which is all important stuff. So then I get the final bit is really, what's next, I suppose. Yeah. What's the next study? Again, in as much as you're able to say.
Yeah. Well, let me make one point is what you don't see in the New England Journal of Medicine report is you don't see a report of central pathologic review. There's a line in there, and we discuss the complete pathologic response as each site read it for themselves. So just regular, pathological review at a hospital. And it was 21% complete pathologic response, which, as we've talked about on another podcast, is one metric. It may not be the only metric to look at. But once we did do central review, which we then presented, at ESMO in 2023, that pathologic response by a single pathologist looking at all the samples blinded nearly doubled. It went up to 38%. So that speaks to the education that we need to have amongst local pathologists reading melanoma specimens that have been exposed to neoadjuvant therapy. What's a pigmented melanophage versus melanosis versus an active melanoma tumor cell. So I think, obviously there's room to learn about pathology, but, the next study that we're going to hear about that really is going to help us here is the NADINA study. This is taking combination, the Prado Apacinio regimen of 2 doses of low dose IPI and 3 milligrams per kilogram Nivo, 2 doses of that going to surgery, and then depending on the response, adjuvant therapy versus the adjuvant approach, surgery followed by a year of PD-1 therapy. So combination versus single agent, but with a big caveat that will not be directly comparable to S1801 for a few issues. The scans don't line up on our 2 studies, the timing of scans. We had to be very real world about our scans. When would American insurance companies pay for scans? And then B, the definition of events, are not necessarily the same. So just, we won't be able to do necessarily a strong cross-trial comparison, but one can only hope that study tells us what we hope it will tell us, which is combination in the neoadjuvant setting is highly effective. And then we can have a nuanced discussion of which regimen, and maybe we need to design that trial, single versus combination with an efficacy endpoint.
Yeah, and it'd be great, I think, to get Christian Blank, and then we can really talk to him when the NADINA data have been presented about, how he sees things and what next steps are going to be. So we'll wrap up. So thank you very much. Congratulations again. Very, very important study. S1801, incredibly influential study. And I think, it's really opened up the field even further and actually made a big difference to patients. So thank you.
Yeah, well, it was the start of our friendship too, I think so. Or continuation, let's say. All right, thank you.